round things off here for the last 5 minutes. We think prospective data is better. Is there prospective data out there? Well, there is. And this was one looking at methadone treatment and what happens to the QTC. And again, these patients were actively enrolled. They got baseline EKGs. They started methadone. They checked a QTC at 6 months and 12 months. What did they find? Well, lo and behold, they found clinical or statistical significance. The QTCs did have a statistically increase in length, plus, what is it, 12 or 12.4 milliseconds plus or minus 23. Okay, but my question is that clinically significant? And again, it's tough because patients are individuals. They have their own protoplasm, milieu issues. I'm buying that this prolongs the QT, but to what extent? And I'm not finding a dose relation a lot of times. Another prospective study looking at QT interval dispersion, another thing that's starting to be studied rather than just QT lengths. How does interlead variation play a part in terms of QTs? Looking at several leads and looking at how dispersed these QT lengths are. This was a single center prospective cohort in a methadone maintenance facility, and basically their bottom line was that there was significant increases in QTCs and QT dispersion. But again, I don't know if you want to say that's minuscule, but it was statistically significant. My question really is going back, is it clinically significant in the right setting? I think it possibly could be. This is a community-based study looking at therapeutic levels of methadone. This is out of Portland, Oregon. It was a medical examiner's study. They basically looked at autopsies over a 4-year period. Patients who came in died of sudden cardiac death. They looked at cases of patients with therapeutic methadone concentrations that they had measured versus other folks with sudden cardiac death who had no methadone on board. And they compared these, okay, and they did their autopsies. What did they find? Well, their conclusion was that cases with methadone on board, there was a significant lower incidence of cardiac disease that patient brought with them. So they kind of made the conclusion that, oh, methadone is probably the cause of their cardiac deaths because I have a lot of deaths without methadone. They had cardiovascular issues. Obviously, lots of assumptions with this study. What level were they drawing? There's postmortem redistributions. What other drugs were they on? Did they really die of a cardiac arrest, or they just die because they were opioid poisoned and they weren't breathing? So not a lot to hang our hat on with that. So based on this data, you're starting to see recommendations to look at EKGs in these patients. Here's a study here, or recommendations here in this publication, to obtain a pre-treatment EKG in all patients who are going to be started on methadone. And interestingly, a colleague of mine at Cook County actually had a patient from our detox center arrive with a prescription, check EKG, send with patient. They're going to start methadone. It's like, my gosh, what a great way to use the emergency department. I'm going to get a pre-screening EKG on this patient, and just interesting that we're starting to see this, hear about it, and that's, again, why I wanted to talk about this. All right, to finish up, I just want to revisit our case and just ask ourselves, is this guy that I presented initially suffering from PMS, okay? We know that he had Torsade, and we know that he had ondansetron that was given to him. That was one of the situational issues in our PMS models. This was a study looking at ondansetron in post-op nausea patients. I think there were like 80-some patients. Some got ondansetron. We already know about droperidol and its effects, but ondansetron did cause prolonged QT. In 5 or so minutes, we see 20 millisecond difference. Minuscule maybe, but in the right setting, and maybe in our setting, it was important. Their study doesn't go into milieu issues. Here's a voluntary study showing in a crossover design, ondansetron caused a minuscule increase in QTC as well as droperidol, but for me, the take home and my message here is both of those drugs together really worked synergistically to prolong the QT the greatest. So that's what I'm trying to hone in on. So what do we do for the nausea and vomiting? Do we give the guy prochlorperazine? Do we give him promethazine? That might be an antiemetic. Well, sorry, there's some in vitro studies that show that prolongs your QT. But we do this all the time. I'm saying this tongue-in-cheek. The denominator is huge of antiemetics that are given without any problems. I think what I'm trying to say is in the right setting, maybe there's problems. Maybe metoclopramide, let's try that. Well, there's case reports, whether they're good or bad is another topic, but potential evidence for prolonged QT. So when I discussed this case at our facility, we have to end it with, what were the clinical errors? And I think for me, and criticizing my colleagues is very difficult because they took great care of this patient, but did they really recognize the prolonged QTC? I couldn't tell by the chart. Did they look at the old charts to see that he had a history of this? You know, the electrolyte abnormalities were quite apparent. There was a delay in giving this guy potassium. They didn't know anything about QT prolongation with methadone. They gave ondansetron. Again, the guy got great care, but I think the biggest error was that they just showed up to work. They were the poor slobs that just got this case. This was probably just inevitable. And they didn't get this guy transferred to the other side of the ER. They didn't pass it off to their colleague. They took care of this patient, and the stars were aligned. This guy had a lot of issues setting him up for just one of those days. And we've all had these days. You're going to have them on the phone with your patients. I certainly have had them in the ED. Experience is what you get when you don't get what you wanted. And I think that's what is chalked up by this case. You know, at Cook County, we're kind of going green. So for these folks who are malnourished, maybe they're having withdrawal, you know, obviously we want to give them fluids, we want to replace their lights, nourish them. We just give them a banana, all right? And if they're in opioid withdrawal, we go ahead and we just give them a bag of this, all right? We just hit that mu receptor, hydrate them, replace their potassium. Anybody know what this is? It's obvious. It's a banana bag. That's the Cook County version of the banana bag. Just kidding. So the QTC, what's important? Protoplasm, milieu, situations. You're not alone if you're confused. I'm still confused. I'm not intrigued anymore by intervals. I'm irritated. I don't know what to do with this other than be aware. I have to think of context. There was a question posed on the medical director's listserv not too long ago about QTs. Great question. Okay, we're struggling. What do we do? What do you recommend when there's an EKG and there's a prolonged QT in the overdose setting? This was the question, and there were several really good answers. You know, what's the clinical context of the patient, this writer puts down. What a great comment. Who knows what their baseline QTs are? I think this provides some interesting food for thought. This group actually wrote back and said, we have 5 of us here, and you know, each of us have a different crash point. And you're going to find that. There's lots of controversy, lots of you know, what ifs, really not a consensus, but we have to come up with some recommendations. I think if you get an overdose patient who's got a prolonged QT, just like in this very good case report by good people, I'm going to follow their recommendations. If I have an overdose patient and their QT is over 500, I'm probably going to watch that patient. Much more so than I'm going to do anything with a patient who I can get good follow-up, who's not an overdose patient, who's got normal electrolytes, who I can maybe send home and get follow-up. But in the overdose patient, that case showed delayed torsade and dysrhythmias. Again, written in the literature, recent, I was at ACEP, a nice abstract. We see QT prolongations. I guess my question still is, what do I do with this? What does this data actually mean? So let's go back to Paracelsus. Is it dose that determines toxicity in all cases? And actually we're finding out, and you're hearing at this conference, there's genetic issues, environmental issues, and I think that's exactly my take-home message with prolonged QTC, methadone, and so forth. So think out of the box, think about the context, think about multiple issues if we're going to be successful here. I want to thank you for your time. I'll entertain any questions. I certainly want to thank my sponsoring institutions, Cook County Hospital, the Toxicon Consortium, and the Illinois Poison Center. Thank you. Yeah, any comments is fine. You don't have to ask me a question, but if you've had cases or you've had situations, if you have opinions, nuances, you know, we can entertain those. I can turn it over to our moderators, actually.
Okay. No questions?
Clear as mud, right?
Thank you, Dr. Bryant. And I'm going to introduce our next speaker. It is my pleasure to introduce Dr. Kirk Cumston. Dr. Cumston grew up in Minnesota, which is commonly called or referred to the land of 10,000 lakes. He graduated from medical school in Des Moines University in Des Moines, Iowa. Dr. Cumston completed his medical toxicology fellowship at the University of Illinois, Cook County Hospital, and Russ Presbyterian Hospital. He is boarded in both emergency medicine and medical toxicology. Dr. Cumston currently practices as an assistant professor at the Medical College of Virginia Hospital in the Department of Emergency Medicine, Division of Clinical Toxicology, and is the medical director of the Virginia Poison Center. The title of his presentation today is Picking Your Way Through the Perfusion Salad of Cardiovascular Toxin Antidotes. With that said, I'd like to welcome Dr. Kirk Cumston. Thank you.
Thank you. Well, missing the title there, but the title of this lecture is Perfusion Salad. And so the idea behind this lecture is that I hope to explain to everybody here that which cardiac perfusion medication would be the best choice in that patient that's hypotensive, that patient that you're trying to get a handle on. You don't know what to do, you've heard about all these different pressor agents, and you kind of wonder why one was chosen, why wouldn't they do something else? So hopefully at the end of this lecture, you will be able to pick your way through the perfusion salad. And I'd also like to say, as Dr. Bryant said too, is I'm very thankful for you having me here this afternoon. And I have no financial disclosures, and even though I'm doing this lecture, I wouldn't necessarily say that I'm an expert. Certainly there are many different opinions here. And so what this is really sort of me going through a number of literature sources to try and put together, hopefully, answers for you when you need a real life situation and you need that answer. So we will start. So here is our salad bar menu, okay?